It's my pleasure to welcome all the delegates that are attending this webinar tonight. Our speaker is the Acting Director General of Health, Dr. Anban Pillay. Dr. Pillay will share his views on the national perspective on COVID-19. A little bit about Dr. Pillay that we don't have the opportunity to tell you. We always put him directly at the podium to talk. Dr. Pillay serves on a number of boards, and just to mention a few, the Board of Medicine's Patent Pool, UNICEF Advisory Board, the TB Market Shaping Action Group. He served as the Deputy Director General of National Health Insurance. I do not think that this is off his radar. I think it's there in spite of him being preoccupied with COVID-19 right now. He has a PhD from the University of Newcastle in Australia. Dr. Pillay will be addressing us and giving us an overview of government's perspective of COVID-19, and he will attempt to answer a number of frequently asked questions on COVID-19. I want to also say that this particular webinar has been coordinated by KZN Doctors Health Coalition and COVID-19 Doctors on Call. So Dr. Pillay, I invite you to address the group.
Professor Chetty, I think this is a great idea to have a webinar at this time. I see you have, at this point, 163 participants. I don't think ordinarily on a Tuesday night that you would have been able to get at this time of the night these number of participants. And it also makes it very easy for us to all connect with each other. So maybe COVID has given us an opportunity to connect using a different approach completely. So I think this is a great idea. I think we must probably continue doing it going forward. I put together some slides on our experience around COVID-19 from a national perspective. I think important for you to get a sense of exactly what the global situation is, those that have not had an opportunity to do so. Using the most recent data that I managed to get off the web, you can see that we have currently global confirmed cases at about 3.4 million, with about 239,000 deaths, which is a mortality rate of around 7%, which illustrates there's about 86,000 cases. And in the last 24 hours from the time of this report, there were 976 cases. Europe still seems to be the most affected area as the epicenter, having shifted from China. And this is where we've imported most of our cases from. But I think the US has also got a significant number of cases. I think moving to our continent, Africa, we still have the highest number of cases relative to many of our neighbors and fellow colleagues on the continent. Numbers in South Africa are significantly higher than any of the others. It has to be pointed out as well that the number of confirmed cases is linked very clearly to your capacity to test. And so in some countries, the testing capacity is fairly limited. And so the number of confirmed cases may be actually lower than the actual cases, given the capacity to test is fairly limited. So I think we need to bear this in mind as we potentially engage with a number of countries in terms of their burden of disease, as well as when we address issues such as travel, etc. So this slide gives you a sense of the number of tests that were done, and these are the numbers that were done as of the 5th of May. We've moved up slightly from this as well. So on the 5th of May, we had about 7,572 cases, which is about 4.6% increase in the number of cases. And the national case fatality rate on deaths as of the 4th of May had increased to about 2%. But we've largely been hovering in this area for quite a long time. as you would have noted. There were about 334 cases at the point. So from the fourth, which was the total cases was 7,238. We moved to the fifth, which was 7,572. The deaths as of the fourth was 148, with the case fatality ratio of a rate of around 2. And we have, importantly, 2,970. So these are individuals that have recovered. So our actual burden is the 7,572 minus the 2,970 as such at that point in time. I think it's important to bear that in mind as we do the analysis. And this was done by the NICD today, and it just updates the figures a little bit. And I think the key issues here to bear in mind is the incidence risk per thousand population. And what you can see is, even from the other figures, that the Western Cape comes out the highest at 54 per 100,000 population, which is a steep rise. And I'll show you some other data around this. And then you have the Eastern Cape as well as Gauteng being close behind, and then KZN thereafter. So these provinces seem to be very closely tracking each other in terms of the majority of the infections in the country. And so 96% of our lab confirmed cases are also in these 4 provinces. Coming to this graph, which is the age-sex distribution of the lab confirmed cases. This was done by the NICD as well for us. What you can see is the age distribution on the x-axis. And you can see a very strong age distribution towards from the 20-year-old through to about 60 years, where the majority of cases are. Interestingly, there are more females than males, which is slightly different from what the global picture is. The global picture is predominantly male as opposed to female. But South Africa seems to have a slightly different picture. There may be some reasons for that. If we look at the distribution of the cases in terms of the 100,000 population as well, which is the table on the right-hand side, you can see again that there's a huge distribution towards the younger age group as well. But that's in the next slide. I think we'll show you the age distribution in terms of lab confirmed cases by male female, and you can see very clearly here that the females are predominant, except when you get to the over 50, where the picture changes fairly significantly. This is a depiction of what's happening in terms of the provinces. You can see that the Western Cape has suddenly taken off. From this point, they were very much following a similar trajectory as the other provinces, but thereafter, due to a number of clusters of infections, largely workplace driven, there were supermarkets, there was a pharmaceutical company, etc., that was infected, and that's largely been the driver of the infection in the Western Cape, as we understand it. The rest of the provinces are following a fairly steady trajectory, not a steep curve as we see there. This table is interesting in that it separates out the public and private sector testing and breaks us down by week and identifies the number of tests done each week. You recall that we only picked up our first case in early March. So you see in the public sector in early March, on the week beginning the 2nd of March, we only did about 309 tests. And at that time, the positivity rate was only 2.6. In the private sector, there were 144 tests done, and the positive rate was 3.5. Thereafter, we had a significant increase in the number of tests. You can see in the week 27th of April, for example, we did 29,000 tests in the public sector, 21,000 in the private. In the week prior, 54,000 in the public and 20,000 in the private. But what's interesting, you would note across both the public and the private, is that the positivity rate seems to be fairly stable, much lower than the positivity rates in many other countries. Even when we get to the public sector at over 100,000 tests, as well as the private sector, operating through completely different systems as such, you can see there's very little difference between them in terms of the positivity rate. And I'll talk more about that just now. So if you look at the public sector, we're using two mechanisms for testing. When we talk about the community screening and testing and the clinic side of things. So the clinic testing is generally those tests where people would come in with the reported symptoms, seeking care, and a test may be done. From the community screening and testing, this is the door-to-door symptomatic assessment of individuals. And these individuals, if they are identified as being at high risk, they then referred in for testing. And here you can see from this data is just from the previous week and then the most recent week. In the previous week, you can see for the Western Cape that the number of tests that were done in the clinic was 3,300, and in terms of the community screening was 3,200. They slightly increased that with the clinic test to 4,900 and the screening and testing reduced. But what's most startling is that the number of clinic positives jumped from 8.4 to 13.5. So did the community screening and testing from 7.3 to 9.5. If we go to the Eastern Cape, we can see there was a small rise in the clinic cases and a decline in the number of community screening and testing cases, even though the numbers that were tested have increased. KZN as well has seen a drop, as you can see, in the number of screening and testing cases, even though the numbers that have been screened and tested has actually increased, suggesting that things in the Eastern Cape and KZN seem to be stabilizing somewhat. In the case of Gauteng, we see that they're dropping their number of clinic tests, so that's reduced, and there's a slight reduction in the screening and testing numbers, but they seem to be fairly stable on the screening and testing rate, but on the clinic side, slight increases there. I think it's important that I just highlight at this point that the objective of our exercises is never to eradicate the viral infection, because that's not a possibility without a vaccine or an effective treatment that would be able to eradicate the organism. The game we're playing is that we need to reduce the burden, which means that we stretch out the extent of the infection, the time period of the infection, so that we reduce the height of the curve. And over that time, we would then be able to accommodate all the cases within the health system. And I think this basically gives you a sense about what our objective is. If we didn't do anything, this is where we would have been effectively. In terms of the number of cases on a daily basis since the first reported case, you can see that since we did the lockdown, it was fairly stable, and then we started picking up, and now it's on an uptick as such, which is in some ways predicted by some of the mathematical models that we have seen to date. This basically gives you the cumulative cases since the first reported case by province. Noticeable again, as I had indicated, the Western Cape, which has had such a significant increase. Gauteng is much lower, at a much lower level. So is KZN, and then the Eastern Cape. The rest of the provinces are fairly stable, very low levels of infection and burden of disease relative to these four provinces at this stage. These are the number of new cases reported since the first case. Again, you can see highly active in the Western Cape. In the case of the other provinces, these numbers are fairly within a narrow band and much lower, significantly lower than where the Western Cape is currently sitting. If we look at new deaths, you can see deaths are, fairly erratic, following an upward trend clearly. But there are days when we have up to 12 deaths, there are days when we have 1 death, there are days when we have 0 deaths. But clearly there is an upward trend from where we've been, which is in line with the number of cases that we've seen. Coming to the lab tests, as I indicated previously, we've done a significant number of tests. I think that despite the significant increase in the tests, you can see our positivity rate still sitting at about 3.2. The NHLS has made a lot of strides in trying to put on new labs. They brought on 6 new labs, so now we have about 17 labs that are doing testing across the country. But that hasn't changed very much in terms of the proportion of people that are actually positive. Clearly, the Western Cape continues to have the highest rate of positivity at 6.8, and the Eastern Cape at 3.6. The other provinces are much, much lower. This graph, I think, just identifies some of our positivity rates and what we call our efficiencies. You can see that the question that we often ask is, are we chasing the right people? And you can see in some provinces that's not necessarily the case. So in Limpopo, they had to do 150 tests before they found 1 positive person. In Mpumalanga, a similar story, Northwest and the Free State and Northern Cape. But you look at provinces like the Western Cape, they just have to do 15 tests to find 1, which means that the community spread and the prevalence is much higher here. So it's easy for us to find those that are sitting with infection in the community. In terms of community screening and testing, these are where community health workers going door to door, checking people for symptoms. Where they are found to be positive, they then referred in for testing itself. As of the 3rd of May, we had 7.6 million people that were screened nationally. Of those, 81,000 were referred in for testing. And so we have about a 1% case referral rate. And you saw from the previous graph that the positivity rate is much lower in this group as well, relative to the others, which suggests to us that we're probably sitting with a lower grade infection at this stage. The other important area is clearly contact tracing. We need to identify those that are potentially infected and being able to reach them and trace them. We are able to currently reach around 92% of the contacts and being able to put them into quarantine. The graphs left on the left, the yellow one refers to the total number of identified contacts. The blue graph is the total, blue bar is the total number of contacts that have been reached. And then the green bar is the number of contacts that have completed the 14 days of quarantine. We're also looking at newer technologies to do contact tracing. There is some developments from an IT perspective that would allow us to use mobile phone technology and Bluetooth technology that would require an individual to switch on a functionality on their phone that then would alert them to persons that they are in contact with that may be at a higher risk of infection. There are various functionalities within the phone that help make that determination. It also has a self-screening application, which then determines whether a person's risk is is green, amber, or red. It also then monitors the person's movement and is able to then identify persons that are in close contact, which would ease our contact tracing. So we're working on that mobile solution. It has been implemented in Singapore and Australia, we understand. And so we would like to try and implement the same, because I think it would really ease the extent of our contact tracing. In terms of hospitalizations, we're not seeing any major issues here. We have the green bar refers to recoveries and the deaths in the orange. You can see that the deaths are still quite significant in the Western Cape relative to the other provinces, and we have a significant number of recoveries, as I indicated initially, about 3,000 recoveries. So our burden is more in the 4,000 category currently. In terms of hospitalization, those that are hospitalized in the green, those in isolation in blue, the orange is high care, then we have ICU, and then those on ventilation and those on oxygen. And what you can see across the various provinces, that they're not really having a problem with the bed capacity or anything like you would see in New York or in London. They're still fairly stable. I think I would describe us being at the foothills of the curve of the surge. So at this stage, it's still a calm. The minister would like to say it's a calm before the storm. But this is where we are currently. So the health system has sufficient capacity. This obviously does give us time to plan for the next phases. Quarantine sites, we have in total about 329 quarantine sites. We have not activated all of them, meaning we've not put people in all of them, simply because they may not be needed. So we activate these sites as it becomes necessary for us to actually place people in quarantine. These provide a sense of the number of total beds that we have. We have about 24,914 beds. In addition to that, we are also building field hospitals. I haven't put this on the graph itself, but we have a number of field hospitals that are in development. In Gauteng, there's a hospital being put up and Nazareth is being converted. There's also be another one that would be put up at Gallagher Estate. And I think there's also another one at Loftus here. In KZN, I know about the plans, or we're very much involved with the construction of the hospital at the Expo, which would be quite an extensive field hospital. We're trying to procure the equipment, etc., for these hospitals. So even post-COVID, we would be able to actually utilize some of that equipment. In Cape Town as well, they've converted the ICC in a number of places into hospitals. The South African military is working with us as well, and they will be putting up some field hospitals in other places. So the idea is, as we hit the surge, we would need to have a number of field hospitals in place, and obviously our intake of human resources will increase. So we would be calling on health professionals from across the board at that time to respond to the potential need as that surge increases. In terms of our Ministerial Advisory Committee, let me say that we are establishing what we call alert levels. You may have seen Minister Nkosazana Dlamini Zuma talk about it, as well as Minister Patel. But basically, we're establishing a Ministerial Advisory Committee. Professor Chetty sits on it, and the committee basically will advise the minister on alert levels. These alert levels will be set at a national, a provincial, a metropolitan, or even a district level. They look at the epidemiological trends, the health system capacity in a specified area to deal with the burden, and any other factors such as hospitalization, infection level, and mortality that may influence what alert level one should be at. They'll also be looking at epidemiological trends such as PCR tests done, number of persons screened, positive cases, recoveries, and the demographic profile of those that are positive. On the health system capacity, as I said, bed occupancy, number of facilities, the human resources capacity of equipment, and related resources. We'll then get to this level, what we call an alert level. This alert level basically identifies what level we should be at. As you know, we're currently as a country at a level 4, but we are moving away from a country level system to a differential system of alertness. And I'll just mention a little bit about that now. But the alert level is basically linked to the risk of viral spread and the capacity of the health system or its readiness to respond to such a high burden. And you'll note that level 5 is obviously the highest and level 1 the lowest. So we'd want to move towards level 1 as we deal with the epidemic. So the lockdown will be eased in a gradual fashion, moving from 5 to 4 to 3, etc. This graph gives you an indicative sense of what the alert levels will look as we plan for the economic activity. I suppose the key point to make is that if you look at the level 5 areas, as from the data I've shown you earlier, Cape Town is clearly an area that's at level 5. So is the Eastern Cape, both the metropolitan cities there, yourselves in Durban, in Tequeni, then in Gauteng, pretty much the 3 districts in Gauteng, in there, Johannesburg and Ekurhuleni for sure, but Tshwane is also part of that, and then Mangaung as well. These districts that are shaded in orange, if I can call it that, are those districts that are moderate level of transmission or at level 4. They generally split across the country. And then there are those that are at level 3, and these are in blue are at level 2. So why is it important to have these levels? Because these levels identify the level of risk. The level of risk then dictates to a large extent the activity that may continue within those districts. So if you have a lower level risk district, you can clearly have greater economic activity, a greater amount of schooling, etc. So that's the thinking around this, and we'll be providing more detail around this model as the details become clearer with time. I'll stop at that point. Thank you very much for listening.
Thanks, Anban. We have a few questions coming through. Guys, any more questions that you have, please send on the chat to everybody. Okay, so I'm just going to read out some of them. Do we know what percentage of positive contacts become COVID positive themselves?
The number of positive contacts that become COVID positive are currently sitting at below 1%.
Okay.
I think the great difficulty around the contacts is that we rely largely on the memory of the individual in order for us to be able to identify them. And that to a large extent is how we operate. Remember, contact is somebody that's been in close contact with an individual. The WHO says 15 minutes. And so we get a number of contacts, but not all of them may be real contacts. But in order to be cautious, we use an approach that is a lower risk.
Okay. Any updates on the psychosocial support plan for quarantine centers to protect patients from societal stigma and consequent danger?
So the provincial departments of health have teams that are responsible for the quarantine sites. That includes a healthcare team with social work colleagues, as well as those from the directorate responsible for mental health and counseling services. We're looking at trying to reduce the period in the quarantine sites, um, for people to continue some of that quarantine at home. We're just finalizing the guidelines around that, and once it's finalized, that we may then require people to spend less time in quarantine. Still be in quarantine though, but spend less time in the designated facility and a little bit more time at their home.
Okay, so we know based on medical records that we have who are the at-risk population, so the comorbidities, the age, the elderly. Is there no program that has been mooted to go to those specific people and test them or screen them?
So that's probably the next phase of the testing currently. But the fear with doing that, though, is that if we simply tested and screened them, they may not necessarily be positive now, but if people in their households are positive, we'd have a different risk. So we've taken the kind of throwing the net widely in order to identify everybody, because if you look at the case of Italy, most of the elderly were affected largely by family members because they have extended families, and that's how the infection actually spread to the elderly, and that's why they had such high levels of mortality in that group. So we would also need to test the others for that reason.
Okay, and then also there's a lot of masses that gather to collect chronic and grants. Someone has asked whether testing cannot be done in these larger gatherings.
That's what we've proposed as well. We've suggested to the Department of Social Development, firstly, that we shouldn't have people that are gathering in this way. We should find alternative ways for grants to be supplied. The President has been very strong on this point with SASSA. We're hoping that they can, over the next few months, change the way they distribute their grants and discourage these large gatherings. But certainly where there are people, we should be doing testing. And I know that in some provinces, testing has happened. In others, I think this may have been a problem.
Okay, the questions are coming in hot and wild, so I'm sorry, I have to sort through them. You know, we have a big issue with the pricing on PPE as it's been, you know, publicized and on the media. Is there any motion to regulate the pricing on PPE?
So on PPE, actually there is price controls for the public sector. So the National Treasury has published all of the PPEs that we require. They've also indicated the maximum prices that should be paid for those. So in the public sector, when you're doing the procurement, you'd have to stick within those procurement requirements. I think the gouging occurs mainly in the private sector. Here, I know the Competition Commission has tried to come in, but that's been a difficulty. I see no reason why the private sector cannot use the same prices that are publicly available from the National Treasury for maximum prices around PPEs for themselves, because whether it's public or private, I think the cost of producing it should be the same. So there should be no reason why they're different.
Okay, there's a lot of questions about asymptomatic patients and testing. What's your thoughts on testing asymptomatic patients, and any idea on how quickly they become positive? That's the asymptomatic patient who is in contact with a COVID positive.
So asymptomatic patients are positive. They just don't have symptoms. So if they tested, they would certainly be found to be positive. Our big problem is obviously because they're asymptomatic, we can't pick them up. I mean, the most obvious solution would be if we could just test everybody. But clearly that's not a feasible option given the number of kits that will be required and the global shortage of these kits. So I think on that front, there's difficulty. The asymptomatics pose a significant challenge in terms of their behavior as well. in that they may, they obviously don't believe they're positive because they wouldn't know. And so their actions may result in spread of infection. That's one of the reasons that drove us to propose that everybody wear masks, because clearly the asymptomatics may be walking around and not knowing that. I think we would reduce a significant proportion of our infections like that.
Okay, quite a few questions hinge around KZN in particular. You know, the provincial health in KZN has not taken up the offer as yet from the private sector to assist or to help. There's a lot of assistance that we as private GPs can, you know, to work together with the DOH. Is there any talks about that happening?
Yes, at a national level there is. One of our thoughts was to establish a national database of all health professionals that would be keen to assist, particularly as we get into the surge, and you know, what areas they would want to assist in, etc., and their availability to do that. We would then take that and ask provincial departments to then engage with those colleagues to see how they can be brought into the health system, that may be working in our fever tents, or whether it's at the temporary hospitals, or it may even be working in our outpatients, so the clinician that's working there can be relieved to go and work somewhere else where there's greater pressure. So clearly there's a plan and a discussion. We will need all hands on deck and more. So there is no doubt that we're going to need everybody, because if you look at the projections of the numbers from the mathematical modeling that's been done, we're going to go into a big surge phase around July, August.
Okay, there's also a disjoint between what national DOH says and what provincial does. So by national DOH, I mean NICD. So NICD says test everybody with a symptom for COVID. For example, you have a sore throat, a cough, or a fever. But when we refer patients to the public sector, to a hospital in KZN, for example, they're looking for more than one symptom or a positive contact test before they actually test a patient. How do we resolve this disjoint?
I think we need to work with the province to make sure that they understand the guidelines better. I think it may be necessary for us to set up some kind of a call center if it doesn't exist. I know there was something that Professor Chetty was working with, whether that can be used for directing officials that this is the criteria and it should be used. It's not clear why they wouldn't want to test such individuals, given that they obviously pose a risk, and it may be more efficient for us to test them and rather than denying them a test and having the risk of them spreading the infection.
On the point of testing, what's your thoughts on the saliva testing?
I've been talking to the private sector about it. I understand that they're currently doing some validation tests. If the saliva test comes on board, I think it's great, simply because the current swabbing has a number of drawbacks, one of which is technique, as well as other problems such as media and all of that, and the risk to the healthcare workers when they're taking samples. So I think using saliva samples would be a big step forward, but I think the validation work needs to be done. I did speak to them again today. They asked for some time to just finalize that validation work, and I think once it's done, it would be something we would be very keen to move on.
So two further points on the testing. The one is that what's your view on all admissions coming into a hospital required to be tested, whether you're symptomatic or not, to prevent catastrophes like we've had at St. Augustine's? And then the second part of that question is, it's a PMB, COVID-19 is now a PMB condition, but
Yes.
if a person is swabbed and the test is negative, medical aids sometimes are refusing to pay for that test because they say it's negative, you're not a PMB anymore. So your views on both of those, please.
Obviously, we would not support the view taken by the medical schemes. I think it's absurd to suggest that you wouldn't pay, given the potential risk. And so that obviously will be a disincentive for anybody to test if you're going to be told, well, you may not be reimbursed for it. On the first point, we're currently testing everybody coming in with respiratory symptoms. That's been the approach we're taking. Swabbing everyone at this stage, we haven't taken that decision. I think it may be something that the advisory committee may want to look at some stage, but I know at this stage, the advice is everybody coming with the respiratory symptoms we are swabbing.
Is there capacity in the state to test everybody en masse?
No, there isn't. I mean, as I said, no country has that capacity. But the other problem that we have is that globally, the producers of the kits are unable to supply us with the quantities that we require. The public sector capacity is around 15,000 tests per day. The private sector capacity is around 10 to 12,000 tests per day. So altogether, we have close on to 30,000 tests we can do in a day. But neither the private labs nor the NHLS can get anywhere close to the capacity simply because they're restricted by the number of kits that they can access. And that's because the producers of the kits just can't keep up with the global demand. I mean, everyone's scaling up. That picture will change, obviously, as the surge in many of the European countries declines. And so I think that may offer us an opportunity to do further testing. So I'm hoping that as we see the epidemic in Europe slowing down, that may help us to unlock some of the resources that are being consumed there currently.
The backlog, is there a backlog from the results that we receive? So every night we receive the results. Is that in the last 24 hours or is that in the last week?
No, that's in the last 24 hours. They obviously have to have a cutoff, and they then go through the results to make sure there's no duplicates, that the tests are actually accurately reflected, because it's a collation of all the tests done by public and private, and then that's consolidated before we get the final result about how many were actually positive over the period, number of tests, as well as the deaths, etc. So all of that happens, and the reason for the lag is we just need to make sure that the figures that we're putting out are confirmed, because errors have occurred. There was once or twice where there were mistakes from the NHLS, and we don't want to report false figures. So we thought we might as well just take some time to report it properly and check the calculations.
Okay, we get a lot of patients calling us looking for their results, right? It could be 5 days, 7 days later. How is DOH giving patients their results? Is there an SMS system? Do they call the clinic? What is the mechanism that they have in place? And then what do they use as a reference for that?
So the NHLS sends the results back to the facility where the sample was drawn, and the patient is then contacted if the patient is positive. Usually the feedback is, if you're negative, then we probably won't call you, and if you're positive, we will certainly call you because the results would have come back. So because we have got such high levels of negativity, it's easier to use that default system. That's what I understand is the approach in most provinces.
It might be, but that high number of negative patients are the anxious ones sitting at home waiting.
Yeah, no, I realize that, yeah.
Okay, so there was a lot of concern at the beginning, and there still is, about patients. You know, we have a large HIV and TB population in South Africa. There was a fear that COVID would rapidly spread to the areas where there is a high density of this disease and have drastic consequences. And that probably is what initiated the whole lockdown. Was this fear warranted, or are we seeing that, it's not so?
So, sorry, you broke up a little bit there. Could you repeat that question?
So I say there was a lot of fear that COVID would spread rapidly in HIV and TB patients and in densely populated area. And this is probably what sparked the lockdown. Was this fear warranted?
That didn't spark the lockdown, but I think that our fear about HIV and TB has not been realized to the extent that we had been concerned. But I do want to hasten to add that this is still early days, so let's not make any final conclusions, and we're still taking them as a high-risk group. I think we need more experience around this before we can be more definitive about the risk to these patients.
Okay, and then one up down your alley. Okay, the rationale to extend chronic scripts to 12
Yes.
months. Okay,
Yeah.
I don't know of any doctor fraternity that was consulted. It raises a lot of concerns with our populations, like our diabetic populations, the HIV population. So in private, we are able to still assist patients getting blood tests done, monitoring conditions. What was the rationale to do this? We can understand not getting patients into crowded emergency rooms and trauma units, but it does affect us in the private sector.
Yeah, so the idea was that we thought that we'd also want to discourage patients from unnecessarily coming into the public health facilities, the clinics and hospitals, as well as GPs rooms, just to get repeat scripts. And the idea was that could they potentially get their script extended? This has obviously been done in a number of countries, and so we thought it was a great idea as well to do it here. We didn't exactly consult with any of the GP groups, neither did we consult with the pharmacy profession. This was largely driven by colleagues in the provincial health departments who wanted the extension so that they could manage their patient loads. But what we have done is we have indicated the Pharmacy Council, which manages the way this will be done, that the intention is not that every script should just be renewed simply because somebody said, well, I've passed the time and I want my repeat. But it's more a case of the pharmacist contacting the clinician and confirming that this is a chronic stable patient and getting some confirmation of that from the clinician. If you're unable to do that, then you can't proceed to actually extend that prescription. So the intention is not to obviously extend the script of patients that are unstable. It's for the chronic stable patient that the prescriber believes can be extended.
Going forward, we're still to enter this peak. Will we have sufficient PPEs for healthcare workers as this unfolds?
Well, we've projected what our needs are. We've taken the model around the number of patients that we'll have. We've then calculated what amount of PPE we'll need. And we've now, communicated that to the large producers of PPE as to how much we're going to be needing in the next 6 months, and National Treasury, so that we can start buying and stockpiling this. So that's the idea, that we would have enough PPE for the surge, because we clearly will need a lot more than we need now.
Okay, the recommendation with reference to healthcare workers over the age of 60 continuing to see COVID-19 patients. What's your opinion, and is DOH implementing anything specific for those healthcare workers?
So these are about healthcare workers over the age of 60?
Yes.
So the advice around those that are over the age of 60 is that they should be aware of the risk that they have. If they are still in employment, they would want to have a discussion with the employer as to what they see as their risk, because they may have some comorbidities as well, which may obviously affect their risk and raise their risk, and then whether they would be open to doing alternative tasks if that's more appropriate, or whether they would still like to come into the office. So there are colleagues that work with us that are over 60 and have indicated, no, I'd rather come in and do the work I do than do something else. But there's others that obviously may be asked to do something, a different task, in order to reduce their risk. So I think the intention is obviously for people to be aware of this, take account of it, and then decide for themselves in the personal capacity as to what impact that would have on them.
Going forward, will hospital, as we see higher numbers of COVID patients in hospitals, are we still going to close down hospitals? Is there going to be a cutoff this hospital has 60 positive patients, therefore we're going to close this hospital? Or is there going to be a different kind of approach to what we've seen, for example, at St. Augustine's and I think it was Victoria Hospital, or Stanger Hospital, sorry.
Yeah, I think, I mean, at this stage, we're still, you know, I think we're not in the throes of the epidemic as yet. And I think we can afford to probably do that at this stage. But I think over time, we'd have to come up with a different plan when hospitals have lots of patients, because that's what's going to happen. These hospitals, I should add, were a source of a lot of infection. And so the thinking is that these places should be decontaminated before they continue to see more cases, because they may well be a risk in such a case. And so that's the reasons why they were closed. But I think over time we'll have to think of other ways, because in the midst of the epidemic we will not be able to afford to close any facility.
Okay, someone's sending me this question a few times. Please advise the early warning systems established to support and contain breakouts at retirement homes and similar vulnerable residential populations. We have seen high mortality internationally. Many thanks.
So we've been talking to the people that run these homes, and the proposal to them is that they should be daily doing what we would call a symptomatic assessment in order to understand what risks exist there. And obviously the general measures that we put in place around social distancing, sanitizing, using a mask. In addition to that, we've suggested that such individuals shouldn't be receiving visitors because that's a significant risk to introduce into a retirement home or an old age home at this stage. So those are some of the measures that we've advised them to take on, hoping that that would reduce their risk significantly.
Okay. We're having quite a few examples of patients that are positive, but there's not an effective tracing route that we can effect. So what we do often is we'll contact the CDC coordinator. Sometimes we can get through to them, sometimes we cannot. We sometimes leave a WhatsApp message for them and hope that the family gets traced and screened. Which is the proper route that we should go through to make sure that we have effective contact tracing, because obviously that's an important part of disease management.
Yes, no, that is the correct route. That the CDC coordinator is the person that should be coordinating the contact tracing. There are contact tracing teams that he or she would work with, and they are in every district as well as sub-district, and so they should have it as their responsibility to receive all of the potential contacts and make sure that they are identified and appropriately advised about how they should go into quarantine, etc., and for testing.
What we can recommend, rather than having 5 different contact numbers or people in a specific area, to have a central number or a central feeding mechanism, and that feeds out to these respective CDC coordinators at the different areas.
So you're suggesting one number for the country or one number for the province?
Well, either, whichever is going to work out better. So we have one portal that we know, we don't need to know Durban North, Durban South, Berea. We know there's one number. This is the number we're going to contact. This is the information we're going to give to the person, and then they're going to refer it to the respective local area person.
No, thanks for that. Yeah, that's a suggestion I will certainly advise my colleagues to see how we can put in place.
Okay, and then the data from Stanford, US, and worldwide is the mortality rate in people under 45 years of age is less than 0.1%. So should the lockdown not be adjusted accordingly, i.e., younger people can return to work earlier, the older people or the at-risk population can return to work at a later stage?
That is one model. The problem with that model, though, is that it also has the other risk, which I mentioned earlier, that if there's a household with the older people as well as younger people, that the infection may not necessarily be acquired in the workplace, but in the household, because some people are moving in and out. I should say I was talking to my colleagues in Russia a few days ago, and they tell me that the picture in Russia is very different. And this story about over 60s is not a Russian story. They have people in their 30s and 40s. And so the mortality rate is equal across the board in all of the groups. So obviously the infection is presenting a very different picture there. So we just need to be aware of that. In South Africa to date, we don't have that scenario, but yeah, that seems to be the case in other countries.
We receive numerous patients that are from the education department, basically teachers, who are receiving these forms about chronic illness
Yes.
and whether they are, can return to work or not. So a lot of them will have diabetes, hypertension, and all of this, and we'd have to list this on this document that they come with. How is this going to impact their return to work and the return of, because a lot of teachers are in the older age group who would have comorbid conditions. That's the first part. The second part is the Department of Health hasn't requested this from nursing staff, and a lot of nursing staff at particular hospitals are also an older population with comorbid conditions. Well, I guess you can extend it all to all fields, really.
Yes, so this will be a ruling from the DPSA, and we were just waiting for the DPSA to make the announcements. I think the teachers kind of ahead of the curve as such. So the announcement by the DPSA, I think, is happening tomorrow, and they will clearly outline those public servants that are considered to be at risk, and will outline the risk factors. So, for example, if it's cardiovascular disease, exactly what aspects of cardiovascular disease will be considered a risk, or if there's respiratory disease, or immunosuppression, etc. So those will be clearly outlined. So there's a clear understanding of which groups are at particular risk, and so the DPSA would make those details available to all departments. We'll then ask our staff across government to then identify themselves and to have a discussion with their employer about what they could do to mitigate against that risk.
At what point would you reopen hospitals that have been closed in KZN? What checkpoints or what measures do you have to follow through before that happens?
The closure of the hospital in those two hospitals were a provincial health department decision, not a national decision. However, the obvious things are that there's decontamination, that systems are now in place at the hospital to deal with infection prevention and control, and that the staff that would return to work have now all been cleared of infection. Those would be some of the key things that would have to be signed off on before they can reopen.
Okay. Medical schemes do not provide quarantine facilities for COVID-19, right? So you can be admitted for an acute illness, but not to sit in a hospital for 14 days. The state facility, the state does have these facilities. Are there any plans to force schemes, medical schemes, to provide quarantine facilities for their members who cannot safely quarantine at home or self-isolate at home?
We haven't explored that. However, I do know of some schemes that have procured hotels. I know about them in Gauteng because we were offered from the same hotels to utilize them for state patients. So some schemes are utilizing hotels, although we haven't made it an obligation yet that they should. These are largely members that have returned from overseas, and it would be inappropriate for them to quarantine at home given their living conditions, and so they've put these members up in hotels.
Okay, the next one is quite a controversial and an important one as well. It's almost 1 million doses of flu vaccines are earmarked for the government sector. Okay, we know from our private suppliers, we've been informed that DOH has requested that a lot of that supply go to the private sector and go to larger conglomerates like the Clicks and the Discam and the Spa groups, who are selling it to the general public, not the at-risk public. We in the private sector are faced with our chronic patients, our patients at risk, who now do not have flu vaccines because of this diverting of stock. How are we going to resolve this in the private sector? There is absolutely no flu vaccine for the coming season.
So the idea of us diverting the stock was to take care of the at-risk group, some of them you mentioned. We did not divert them to these groups. The agreement was that stock would be given to the department for specifically dealing with these groups. In addition to that, I haven't researched how these private corporates got their hands on the stock, but the commitment of the companies was to give us that quantity, and so that's our agreement with them. This additional stock, I must say, I'll have to investigate and come back to you about how that stock got to them. But it wasn't facilitated by us, that I know.
We've heard today about medicine or medication or some kind of treatment coming from Madagascar. Any updates about that?
So the Madagascar treatment is artemether, which is used in malaria, as you know.
Malaria.
And I think there is some misunderstanding that it would be effective in COVID. We obviously have no interest in it. It has been offered to some countries on the continent. It may be effective maybe in assisting with fever, but I think beyond that, it's going to have very little value.
Since COVID, and a lot of our effort has been diverted to coronavirus, has any of the other important things like TB and HIV been deprioritized to deal with coronavirus?
I wouldn't say it's been deprioritized, but I do think that our monitoring systems and resources towards supporting the program has not been what it has been previously, simply because all of us are focusing on this outbreak. And so where there are potential problems, those would be exacerbated simply because we're not kind of watching that closely. I have heard reports that in some clinics, patients have been told, if you don't have coronavirus, don't come here. We're not interested in any other condition. And so those are the kind of challenges we've had. But we have not kind of deprioritized them as such to that extent. But clearly our energies and efforts are largely linked to responding to COVID.
Okay, I'm going to leave it down to two more things. How often will lockdown be reviewed or the grading be reviewed? Is it provincial or national? And then the other is a request for more data. So we seem to be data deficient in KZN in terms of district, in terms of stats and stuff. We get a lot from Western Cape, from Gauteng. Our province, or KZN province, seems to be a bit deficient in that area. So can we ask for more stats going forward? And then the lockdown query.
Yeah, I mean, it's as you know, we live in very much a federalist state in some ways, but we will be publishing national stats that include provincial stats. So our plan is hopefully by next week we'll be ready to go live with information about every province and district, and the statistics broken down, not just at a national level, but going a little deeper at a provincial level. The data or the decisions about the alert levels will be revised probably every 2 weeks is what we're thinking, looking at the data and what the trends look like. As I said, the advisory committee will make a recommendation to the minister in terms of what the alert level will be. That will then obviously drive the other activities, particularly economic activity, because the economic work stream will only allow businesses to continue once we reach lower levels of risk in a particular area.
Sorry, one last question. Are all post-mortems or patients that demise tested for COVID? For example, if somebody dies of an infarct, do they also get tested for COVID, or is it only by suspicion?
Our recommendation in the guidelines is that all patients should be tested for COVID, so we can identify the mortality linked to COVID, as well as go back and review the case history around such patients.
Thanks, Anban. Guys, if you have any further questions, please email it to the office. We'll collate it, and if we can, send it to you, Anban, for further answers. Prof, from your side, is there anything you'd like to say before I hand over to Anushka?
No, not really. I think Anban has had a long night with you on board. I think we should give him a chance. We should give Anban a chance. I think we should just ask Anushka to bring the evening to a close. I just want to say, Anban, thank you very much. Maybe in a week or two from now, we probably would engage with you for another update. We've had a very good turnout here, so I would just say back to Anushka, and we'll ask you to save a date for us.
Okay, there's just a couple of closing points I forgot to mention, if you don't mind. I think I spoke about the fever tents, and I think we would like to set up a triage site outside all of our facilities, so we would be able to divert infected patients there, or potentially infected patients, so we can triage them without putting the other patients at risk in the hospital. And so we're planning to put that up at various sites. And I think we will probably be opening up a lot of opportunities for people to participate in that. The other issue I just wanted to highlight is CPAP. We're getting a lot of data that suggests that if we can identify patients early that are at low levels of oxygenation, and if we can put them on CPAP, we may potentially delay the need for ventilation and the adverse outcomes of ventilation. The data out of the US, I know, is very frightening. 88%, 90% of those that are on ventilation actually don't make it. However, the picture in Italy is very different. And getting patients onto ventilation early, putting them on CPAP, has shown very good results in some of the Italian reports we've got. So I think there's a huge opportunity for particularly GPs to identify these patients early. They may not present as patients that would be needing ventilation, but I think if we need to just look for it, because it may actually prevent us from going through to ICU and ventilation, etc. I thought I could just highlight that point. I forgot to mention it earlier. Thanks.
Anban, thank you. On behalf of the KZN DHC, represented by Prof. Niveen and the COVID-19 Doctors on Call program, really like to express our appreciation for you making the time to answer our questions and engage with us. I think the one thing most of us have found is that this crisis has really brought all of us much closer, and the engagement has really been a lot stronger than it has been in the past. On that note, I'd like to take the opportunity to invite all the doctors on this call to join the Doctors on Call program. We take a few hundred calls a day from very impoverished communities around the country. We really are in great need of doctors joining us as we scale up and as we try to continue to serve our communities. If anybody is willing to take maybe 1 hour of calls a day, please, or 1 hour of calls a week, please contact us and we'd be delighted to onboard you onto the program. The program is a pro bono program. We've done more than a few thousand calls over the last few weeks, and we hope to continue to stand beside the province and beside National Department of Health as the crisis escalates. We think that this is a great contribution we can make as the doctor community of the country, and we'd really like everyone to be involved with this program. So on that note, I'd like to thank everyone, Anban, Prof, Niven, and the rest of the team who've joined us. We will make this video available, and Dr. William Mapum from Vula will circulate the link. So thank you, everyone, and good evening.
Thank you and good evening.
Thanks, guys.
Thank you, Anban.
Thanks, Morgan. Have a good evening.
We had a very nice crowd. I think we had just about 250 for most of the day.
Yes, yeah.